We have another speaker joining us at this point, and I'm going to let him introduce himself.
Hi, it's an honor to be with you guys this morning. My name is Eric Van Houten. I'm the CEO or Division Manager for the Community Health Centers in Lane County. And I was offered an opportunity to join these very esteemed two to talk from a perspective of launch. We've done this since the integration since 2005 with some successes and challenges, and I'll talk more about that at about 11:30. But I'm going to be with you guys through lunch.
Right. And so I will go ahead and just talk about a couple of examples of launching in different settings, and then turn it over to Kirk to talk about the readiness assessment tool and have you guys start working in your teams. The first example is a pediatric clinic, and in month one, they developed leadership consensus. They ratified a manual that described the program, and there was didactic training for two behavioral health providers and their supervisors. So they were already like, well, we got to think about backfill and that sort of thing. And then we started core competency training, which is really on-the-job training, where I go into the clinic and model various things and address system kinds of problems. Months 3 through 5, a lot of, in months 1 through 2, also training the primary care clinicians and nurses on a variety of things like you're going to be trained on this afternoon. And then they were able to start pathways addressing overweight, obesity, parenting, neurodevelopmental screening. It was like 6 months to get a child in for an assessment of neurodevelopmental delay kinds of problems. So started screening and kind of a 2-stage screening and intervening in the clinic. Started a healthy relationships class for adolescents and created a pathway. We had problems with kids who get expelled to school and they had to get certain kinds of services, evaluations before they could get back in school. Well, that was something that could be done there in the clinic. And furthermore, strengthen our connection with those kids that were vulnerable for a variety of reasons. As will happen, one of the BHCs, all trained up and rocking it, left in month 11. So that gave us an opportunity to do mentor training with one of the other BHC who co-trained with me while we trained a replacement. So then the clinic is sustainable within a month. They've got somebody that can train, and they've got multiple pathways going. This is an example in the military. I mentioned in the Air Force. They started in '98 with a pilot study. They got their manual together. Again, a train-the-trainers approach is very workable in this transition in the primary care home. Expansion from just select clinics to worldwide by year 7. Can you imagine an America with a behavioral health consultant as a part of every primary care practice? I mean, I can. I mean, in some practices, probably patients would see the behavioral health consultant before they saw the medical provider and saved medical visits for what needs to be done in medical visits. Anyway, revisions to the manual, that's also something it launches a continual kind of process. It's a lot of times people get started and they don't have a manual, or they forget about their manual and things come up. But to be able to have a process where you're revising and you're focusing on expansion and sustainment. So in the Air Force, in year 16, they now have twice monthly webinars. One is question and answer, and one is content focused. They have 170 behavioral health consultants that connect on these webinars and talk to each other and share information and learn new things. So ongoing, this process of launching and changing. And it all starts with kind of like taking a moment to reflect and say, where are we at this point? So Kirk will take it from there and introduce you to your readiness assessment tool. Everybody has a copy of that, should, at your table. You can kind of pull that out at this point.
Should be in your folder. It'll say Organizational Readiness Tool. Does everybody have one of those? We're going to play a little game. And the game is called, How Consistent is Everybody's Impression of Where We're At? One of the things Patty and I have learned early on, having worked with so many diverse healthcare system settings, from single clinics to huge systems like the Air Force, is everybody sort of says, this is a really cool idea, let's do it. Not realizing that you're basically redesigning primary care, right? And so a redesign, if you think about this as part of the redesign to the PCP, PCMH, when I say PCMH, that acronym has been emblazoned in my mind, but it means the medical home is a redesign. It isn't just throwing people willy-nilly into the same space and sort of assuming that they will know what to do. And in fact, some of our biggest disasters, not ones that we were responsible for, but we have a dial-a-priest number in our office. Some of the biggest disasters that come in on that line are where people thought this was a really cool idea, let's just kind of throw somebody in there and it'll be beautiful. The angels will sort of descend on us and we will march into the sunset, in a state of bliss. In fact, there's a set of steps that you need to follow, and the purpose of what we're going to do is to kind of see, since there's multiple people from each clinic here, it's a chance for you guys to do an assessment without talking to each other about where you think your clinic is at, and then after you've done that, we're going to have you compare your answers among yourselves. So we often will do this when we do longer trainings on site, because A, people have a really good time at this, and then they get in arguments about, why did you think we're not ready? I thought we were ready. And I'm sure that never happens in any clinic that's represented here, but it sure happens at mine. And there are some domains, and if you think about these domains, they're kind of sequential in a way. These are kind of the ways that redesigns tend to unfold. At the first level, it's sort of a political and organization-wide process of talking about and adopting an idea at the highest levels of the organization, and then beginning to proliferate that idea down into the ranks, so you're affecting people that are practicing. You're also trying to deal with people who are the chronic naysayers. Do you guys have chronic naysayers in your, or I thought they were all Husky fans but at this point. And so you'll see in that domain, there's 8 or 9 things that really need to be done to assure that we have buy-in up and down the stream of the clinic, all the way down to the level of staff. So there have been times when I've been called in to do workshops on site in primary care clinics for the staff, not the providers, to just talk about, this is what we're trying to do, this is why this is a good thing. And why would you do that with staff, like people at the reception desk? And because if they don't have any idea what you're doing, it just feels like another one of those top-down things, that all of a sudden my work has changed and I don't even know why we're doing this, right? So that's domain number 1. My experience is when you have very strong scores in domain number 1, it tends to flow into the other domains because people are working off the same sheet of music. Domain 2 is you've got this idea and basically people are on board, but you really haven't defined what the program is, what kind of services are we going to deliver, what's not going to be delivered, and kind of what the philosophy of the program is, like Patty was talking about. Behavior change is the most powerful form of learning. Skill deficits are kind of the the main reason people get in trouble in life. That's a philosophy, right? And so providers of all types have to kind of embrace a philosophy of care, that integrated care is better than segregated care. Or when we have people leave our facility to go get some specialized service somewhere, that's where people fall through the cracks. They don't get there. So we don't want that. We want to do as much as we can inside of our clinic and very seldom have to have anybody leave. Because when they cross systems, that's when you lose people, right? That's an example of a philosophy. That eventually gets culminated in a program manual document, which will come up in an operational way later. Usually the next step is somebody says, well, how are you going to pay for this? We actually made it an hour this morning without somebody asking that. That's some kind of world record, right? So, we're not floating around in the ether, we're not that bad as psychologists. I mean, we're psychologists, but we're actually pretty business savvy. You have to make the financial case, the business case, and you also have to sort of figure out what are the payment mechanisms, how is this going to work out financially for us? And I'm not going to go into that in depth other than to say there's a lot more impacts from a behavioral health consultant than the direct billing revenue that they generate. For example, Kaiser Permanente Northern California was our first large project, 2.2 million consumers, 17 health centers, all of which are just about the size of Portland when you actually get to them. When they implemented this model, basically in 1999, 2000, they discovered through very, very systematic financial measurement that they were increasing physician revenues, physician-generated revenue by 12 to 14% per clinic. Because their whole thing was, when our physicians get tied up seeing a patient who's crying, bawling, got multiple problems, and they had a scheduled visit of 30 minutes and it went to an hour, somebody in the waiting room got up and left, the physician gets 2 of those in a row, basically now we're going to lose a lot of, in Kaiser they call this, what was it? It was a model of lost cost, basically. So what they discovered is when you have behavioral health consultants around, the lost cost ratio goes down to almost 0 because you can hand people off. If you sense trouble, you just call the BHC, you're out of that situation, now you get back onto your schedule. It's just an example. The other thing to consider is pay for performance. Have you all heard that term? It's coming your way, coming to a country near you called the United States. Pay for performance means if you don't get a good outcome, you're going to get paid half of what you get, as if you did get a good outcome. Let me give you an example. Depression, treatment alone by a primary care doctor, about 35 to 40% of patients get better. You add a BHC, that figure goes up to 70. So at 70%, at a full response, you're going to get paid twice the amount for a depressed patient's care as you will if they don't respond, and you will be producing things like PHQ-9s to verify that people got better. Does everybody know what a PHQ-9 is? Okay. So it's just a brief depression screening tool. That day is coming, so actually you start looking at people in the mix who improve outcomes are going to be incredibly important to your payment schemes. Those are just examples of the arguments that I've had and heard, but you have to get through it because it's an investment and some of these things are not known, right? We're still at the cutting edge of a lot of this. The research is looking real promising, but the fact is you have to kind of make an investment. The next area is program mission, scope, and tactics, and this is kind of where we really define the service model per se that you're going to use, okay? And those are things like job descriptions, excluded services, reporting relationships, and we'll take you through a sample program manual in your BHC toolkit, PCBH toolkit. There's an example of a manual like that put together to describe. a program. If you go for NCQA, JCO accreditation and that kind of thing, you can append this to your primary care documentation, and essentially you will get huge bonus points from both organizations if you're not doing a PCMH certification, but if you're just trying to get general accreditation. So you don't have to have it set up as a separate behavioral health accreditation. It's just part of your primary care program. The next area is administrative infrastructure. This is on page 4. And you can kind of see what we're doing is we're working our way down the ladder of getting more and more detail-oriented, getting more and more, what is this going to look like on the ground? Where are the chart notes going to go? What should chart notes look like? What is the schedule template going to look like? All these things, you know, you can't just figure we've got this really cool idea and we're going to go into the hallway without any of this sorted out. You will have a nightmare on your hands. You have to sort out what does the operational platform look like. The question about exam rooms is a very common one that comes up. You know, that we've got to figure out how to keep doctors flowing. We can't take away space that generates revenue, so that means we've got a logistics solution that we have to put in place. You know, I need to keep the person in the area where all the action is, because if they are too far removed, then they can't come in and they can't increase my provider's productivity because they're not going to get called in, but I can't have them taking up an exam room that would otherwise be full with another patient. And that's a fairly common theme we hear, you know, we don't have any space. I think there's one architecture firm in the world that has designed all primary care clinics. Because you can walk into one anywhere. I mean, we do this in Europe, and they smell and they look exactly the same. Right? One of our former colleagues used to call us non-sync therapists. Patty was joking about, we're non-sync clinicians. You know, and when times get tight, the sync clinicians get preference. People that use a sync are valuable, and the non-syncers aren't. The next area is training, and this is, of course, what we do. And you know, you can have some really brilliant process up to this point, and then you save $10,000 or whatever in your budget by not doing training, and guess what you got? You got doctors that don't know what they're doing with this integrated model, and you got behaviorists that don't know what they're doing. So again, I think all of these things are natural sequelae, so you know, kind of what should the training look like, how much should we invest in that? That's another domain. And finally, your performance indicators, which is no longer really negotiable. I mean, there used to be this ethic that some health centers had, that we don't do any program initiative where we don't measure whether the program did what it said it was supposed to do. And now the government's basically going to intervene and basically say, you're not going to do any program initiative without showing us that the initiative works, and the payment's going to be tied to that, right? So it's just an ethic, and we're going to talk later this afternoon about some matrix, outcome matrix. What do we mean by an outcome in this model? Who are the stakeholders? What are we actually trying to measure to make the sense of this, right? Most of you, when you go through this, I'm guessing will find that your readiness scores are pretty low. But it would be interesting to hear if somebody had high readiness scores, because that would be unusual at this state of development. So don't be discouraged as you do this if you have lots of 1s and 2s on this 5-point scale of success readiness, because you're just starting, right? So the way I use this is to think about it as a gap analysis, and that is there's going to be areas maybe where we disagree in perception, but when we talk about it, maybe we weren't so far off, maybe there was a way we were interpreting the language and maybe we were closer. And then there's areas where we truly are just we're not ready. This area is going to kill us. And that's what you use a gap analysis for, is that can be, you can turn right around and develop a work plan to say this is the area we're going to commit ourselves to developing. And in fact, at the end of this exercise this morning, we're going to ask you to commit to 3 specific, not domains, but maybe targets reflected in this long measure. So there's, I don't know how many total questions, but probably 49 or 50. You're just going to pick 3 areas that you agree from your clinic perspective. These are the things that we want to focus on to start with. Everybody clear about that? Each group, did you get a chance to kind of talk about maybe 2 or 3 strategies, or did you just kind of talk about the area in general? Or did we get specific? Okay, so over there, what did you guys specifically decide you were going to do?
Come up with a service manual.
Okay, you get a star on the reward chart that lets you go to a movie on the weekend?
We're going to make a movie too.
Okay. You're going to make a video? Okay. Great. How about somebody else that came up with something specific? You didn't have to. Sometimes you have to cogitate about this stuff and argue about it a little bit. But did anybody else come up with sort of at least one distinct thing we're going to try to get done here? Yeah.
Talked about an idea of having an assistant for the PhD,
Okay.
like an MA.
Mm-hmm. So kind of an operational flow detail. Good.
Other targets?
We had good buy-in from the heads. We need to filter that down in staff training.
Okay. Okay. A very common oversight, actually. We think, because we believe in it as the administrators, that everybody else implicitly understands it, and so we need to kind of walk down and start talking.
We talked to them about it, but they're not buying in from what I'm saying.
Okay, so we have a buy-in problem. Anybody else come up with something specific? Okay. There's a number of ways you can use this information. You can have other opinion leaders or administrators, physician leaders at your facility do the same thing you did today and just add to the mix. I've worked with facilities where they went line by line through every item. I know, I'm getting there. You can go line through line and actually then go on an item by item basis, just comparing people's perception, which is very, very useful. It's just too time consuming to do it here. So actually, I would encourage you to get to the detail of each of those lines in some way and find out, why are we seeing this different, or this, we all seem to be giving it about the same rating, it's high. Maybe that's not something we need to worry about. So before Eric comes up and talks a little bit about their experience with implementation, we also wanted you to try to find a sister clinic that you could kind of share your experiences with as you go through maybe some of the implementation process. And we had how many? We had quite a few rural and urban.
Right. What we'd like you to do is, work further on this in your teams. Spend more time with it and really go forward. Too many times we reflect a little bit, we come up with some ideas, and we leave the conference and forget about it, right? So we don't want that to happen. So we want you to identify a sister clinic and to check in sometime during the next month on these things. For each domain, what your score is, what your planned action is, who is responsible, and when you're going to review it. So it would be like in mid-November, you'd get together and then you'd contact your sister clinic, someone on your sister clinic. So I think you can choose your sister clinic based on somebody that's a little bit ahead of you, somebody that's facing the same kind of problems. So I'm just going to go by domains and have people raise their hands. And then I want you to choose somebody that's going to be a sister clinic for you. I think I might also say rural or urban, because I think some of the differences, some of the challenges are significant. You're going to come up with different solutions. So who is going to target political and organizational? Okay, anybody else going to work on that? Okay. Are you guys, would you call yourself urban or rural? Yeah, okay. How about core program philosophies? How many people working on that? Okay. Anybody rural that got a score of 3 or over on political and organizational? You're in a group of 1, no matter what I say. Yeah? Oh, okay, maybe you guys can be partners, exchange information. All right. Financing strategies, anybody going to take that on? Okay. You two be partners and support each other on that? Okay. Exchange information. Program mission, scope, and tactics. Got one group over here, and we've got a group back there. Okay. Say the name of your clinic. The name of your clinic. Villa Medical Clinic.
No, that's not us.
Portland Integrated.
Oh, Portland.
Sorry.
Portland Integrated. Yeah.
Emmanuel.
Emmanuel. So y'all be partners? Oh, Emmanuel. Okay. Administrative. Okay. Quite a few people. Are y'all you're all in the same clinic? Okay. We've got someone back there also working on administrative. Can't read it from here. Your clinic. Nope. No one else working on administrative. And you guys are rural, right? Yeah, okay. We'll look for somebody. Staff training. Okay, good. So we've got 2 possibilities over there. You guys can work with each other and with, so you find each other at lunch and exchange information.
What's the name
They know them.
Okay,
They know.
because there's 3 different
Yeah.
clinics in that.
Okay. Performance indicators. Okay. Is that 2 different clinics or? Yeah. That's 1 clinic. Okay. Anybody else interested in performance indicators? Anybody have scores under 3? Yes. Maybe Sandy, y'all could check in too. Okay. Okay. Sandy is Columbia Hills, right? Yeah. Okay. And back to administrative. Anybody rural that had a higher score on administrative? Want to lend a hand? No. Anybody with a lower score in administrative rural that wants to support each other? Not an area. Okay. Well, you have to check in with us and tell us, yeah, as your facilitators. Okay, so don't forget about this, You got somebody else to kind of hold you accountable and for you to hold accountable. And the devil is in the details. You want to make a strong program, you got to work with those details. Did anybody not find a dance partner?